Okay, this is the second video. We are continuing from slide 56. This is in regards to part 2 of the neurologic system. So in slide 56, sorry, um, the point that I want to point out is in the second bullet. Once again, we're talking about the RAS system and how it affects symptoms and the process. Then in slide 57, notice the unique cases being infection through the urinary tract, which is in general part of the renal system, which is a very important system, and pneumonia and surgery. This is, of course, in regards to delirium. Um, then on slide 58, the first bullet talks about the unique symptoms. You can see the drowsiness that we've talked about before, changes to movement, um, and then short changes to short memory and recall, which are part of or classic changes due to problems in the nervous system. Then I suggest that you literally read the second bullet on slide 58. It's kind of it kind of summarizes um, all of the nervous system's symptoms in one bullet, which are possible symptoms because you have the nervous system affected. Then in slide 59, notice for the first bullet, we're talking about a more chemically based process. In the third bullet, notice that possible causes include fever. The nervous system and nerves are very sensitive to changes. When they heat up, meaning that they're getting hotter and hotter, you get dysfunction of the nervous system. We can see this even in healthy people where their body temperature accumulates and they start suffering from neural systems that disappear once the core temperature goes down. So this is an interesting uh, um, phenomenon. Then I'm going to continue to slide 61. We're talking about dementia. Notice in the first point bullet, the idea of progressive failure, okay, in multiple functions. Then the third point or bullet, when we're talking about causes and we're talking about compression, this is, of course, by nature mechanical. So you're creating or you're affected by a mechanical pressure. Then going to slide 63, talking about the Alzheimer disease. Notice it's a disease. And since it's idiopathic, we can talk about risk factors. This is a principle that you'll notice as well. Once something is idiopathic, we associate risk factors to it, but don't necessarily have a profound link. And then you can see the three subtypes that talk about timing versus so early or late, and then is there a family history or not. Going to slide 64, talking about the unique symptoms in the third bullet, notice that we need imaging abilities in order to notice the unique symptoms. Okay, slide 67, if we talk about the first bullet, we can connect this to the Fick equation that plays between, so to speak, or is made up of two major components, the ability to deliver and the ability to extract or utilize. So we see this when it pertains to blood flow and oxygen delivery. The Fick equation is very important. And then, of course, how can we avoid in this system the idea of mechanical pressure? Then in the second bullet, a very important part of the system and understanding function in general. or physiology and exercise physiology in general. We can talk about the cerebral blood flow and fluid, and of course the perfusion pressure, which is obviously an immediate influencer of function. Then we can talk about blood volume. So we have three major components here that are extremely important to the understanding of function. This is also a great place to understand what is going on in the balance between O2 and CO2 that may lead right to acidosis or alkalosis. Then in slide 68, just want you to remember the idea of fluids and characteristics of fluids and their behavior. So when we have fluid buildup, you have pressure buildup. If fluids do not have a place to escape to, and you're going to try and condense them, they are going to push back, and that by definition will elevate the pressure in the area and cause cell injury, cell damage, right? And so slide 68 immediately leads us to IICP, which basically is the idea that when oxygen is lacking, one of the compensations that we try to do is elevate delivery, so the volume of blood, in order to compensate. That by itself creates a gradient, or it does not create the gradient. It takes an existing gradient and changes the balance within it, causing pressure to go up. This is a classic response. And then you see in the third bullet of slide 70 that edema is part of the outcomes or causes, because this is exactly what's going to happen when you have a gradient where the pressure is pushing fluids to a certain area, or causing fluids to accumulate in a certain area. Then slide 71 is exactly the idea of a pressure gradient, as we have spoken about and learned about in the very first lesson of the class, and it will reoccur again and again and again. Then notice that slide 72 just explains to you how the gradient becomes zero. If the gradient is zero, then you have no gradient, you have no movement. That usually is not a good idea. As you know, gradients that are greater than zero help passive processes of the cell and the body happen, and usually promote life of the cell. Then you can see in slide 73 that we have brain tissue moving around. Literally pieces of your brain moving to a place that they're not supposed to be. That is bad. Okay, let's keep it simple. Moving on to cerebral edema, slide 75. Once again, the same idea, the same mechanism again and again and again. An increase in volume causes an increase in pressure. Remember, we're talking about the skull. We have limited space. There's not a lot of room to move to. Besides the fact that even if you had room, it's not a good idea to just disperse an organ or tissue. It doesn't work no matter how you look at it. So notice also in the third point or bullet of slide 75, you have the displacement of brain tissue. Not a good idea. Deciphering a bit slide 76, it's not too problematic. Just to go over it, when we're talking about vasogenic, we're talking about at the organ level. When we're talking about cytotoxic, we're talking about at the cell level. When we're talking about interstitial, we're talking about in between cells or in between tissues. Then notice in the third bullet, there is a barrier, a very important barrier to understanding function that we will revisit again in the course, which is the blood-brain barrier. Very, very important for measuring different situations or conditions and affecting the higher um, levels of function of as perceived in the higher centers of the brain. Core temperature, oxygen, CO2, very, very important location and place. Um, Slide 77, the third bullet pertains to the idea of active transport mechanism. This is a very important mechanism that will influence the literally the livelihood and function of the cell. So this transport mechanism is vital for life at the cellular level and hence at any anatomical and functional level. Slide 78, a reminder of the rule: fluids follow sodium. Remember that when you're going through the slide. Then in the fourth bullet, took me a second to count the bullets. We're talking about the myelin sheath. The myelin sheath is cardinal to the function of neurons. It protects against infections, so it's important to the immune system, in this case, the innate immune system. And it helps function by accelerating the conductance of the neural impulse. So this is very, very important. And when the myelin sheath is affected, that is not a good idea. Let's see, slide 79. Notice that when we're talking about hydrocephalus, we're talking about the same ideas and mechanisms, just a different location. And notice once again, second bullet of slide 80, pressure goes up because of fluids that are captured in an area that is confined. Same idea. Then we can talk about slide 82. Rapidly developed IICP, deep coma, because things are happening fast. Confined area, pressure is going up because fluid and tissues increasing the force on a on the same area or space. Let's say it that way. Then in slide 83, the last 2 points talk about exercise. Obviously, this person should not be exercised until cleared by the physician. This is usually a few weeks after treatment has been effective. And then we can talk about exercises that improve balance and coordination, stretches, and so on and so forth because of the weakening of muscles. Let's go to slide 86 that talks about hypotonia. So decreased tone of the muscles, meaning you have a loss of stability, which is important for safety and day-to-day function, and firmness of the muscles. So the muscles are not firm, which in turn affects stability. Whereas in slide 89, we talk about hypertonia, meaning that the muscles are highly active. They are stimulated all the time by the system. You have, in a way, an overload of neural commands or an axis of neural commands that keep the muscles working. This, of course, elevates metabolic demand and makes the muscles usually stiffer. So it's almost, not exactly, almost the opposite of hypotonia in the mechanical sense. Um, let's go to slide 92. We can talk about rigidity as being a matter of the muscles being a bit more fixated, whereas spasticity, hypertonia, is a matter of more the muscles being agitated. There's a fine difference between the two. And then you have the mechanisms there. Um, then we can talk about parotonia in slide 93 as including involuntary resistance to passive movement. Okay. And then when we talk about dystonia, the idea is the repeats of the involuntary movements. So small differences in definitions there. Um, then if we talk about motor neuron paresis versus paralysis or paralysis, we can talk about in the first bullet about paralysis being an incomplete or partial paralysis versus complete paralysis. Then on slide 96, although it's a title, I wrote a remark to remind you of the difference between the higher centers of the brain and the lower. The central neural system pertains more to the higher functions of the brain, the higher centers of the brain, which are which usually pertain more to the more cardinal aspects of existence, supervision, regulation, and so on and so forth. Uh, let's see, slide 97, we're talking about in the second bullet, the idea is that in this case it's one-sided, whereas in diplegia it's in both sides or two-sided. Then notice in the fourth bullet of slide 97, we're talking about the lower spinal cord, meaning we're going towards the lower centers of the brain versus the higher that we talked about prior. When we're talking about the pyramid in slide 98, we're talking about going from up to down, from high to low in regards to the centers and the functions that are affected. So from high function to what we call basic functions. 99, we see the effects moving downwards. Obviously, because we are anatomically or structure-wise moving downwards within the systems or the system or the centers. So the same thing happens to where the symptoms are going to occur. Then notice in slide 100, first bullet, that spinal shock is usually resolved within days or weeks, usually, not always. We see that the system accumulates both mechanical and chemical stress, and that stays in the system, and that's not a good thing. So it builds up. Okay, that's in regards to post-shock or the second bullet on slide 100. Then we're going by definition to the lower motor neurons, or what we call peripheral syndromes, because the lower you go, the more peripheral you go, the higher you go, the more central you go. So we're talking about being located in the spinal cord, as you can see in the first bullet of slide 102. Then we can talk on slide 103 on low reflexes or low levels of reflexes, meaning that you have a lower or less protection to the body, because that is the nature of reflexes. Then in slide 104, in the second bullet, Notice we're talking about poliomyelitis. TIS at the end is the indicator for an inflammation or infection, so that gives away the whole idea. 105, slide 105, we're talking about something that is segmental, meaning it is localized. And then in the third point, when we get to the point where the nerves nuclei in the brainstem, in this case the cranial one, is involved, that is a more severe level than what we've talked before. Then we see in slide 106, second bullet, that damage may spread, means it might become systemic, or might start affecting other functions in other areas, which is worse, of course, if it's spreading. And then the third point on slide 106 talks about the genetic basis, or a possible genetic basis to the phenomenons. Jumping to slide 109, we are talking about hyperkinesia, meaning the symptoms, the phenomenons include excessive movement. And in this case, we're talking about abnormal, obviously, because we're talking about a pathology. Going to slide 112, we see that when we're talking about HD, the conditions, the symptoms progress to the whole, to the entire body, which is bad. Slide 114 or 113, talking about hypokinesia, little movement or less than normal movement. Notice in the first bullet, the part where we're talking about there is no loss of consciousness or peripheral muscle and nerve function. Okay, so that's very, very distinctive. Then regarding slide 115, when we talk about akinesia, we're talking about the extent of movement. In the second bullet, when we're talking about dopamine, dopamine is a very potent neurotransmitter. Then in the third point with bradykinesia, we're talking about the pace, not the extent. So there's a difference. Notice the word slowness, labored. Okay, so that talks about how fast it's occurring or not, the pace of the phenomenon versus the extent in the first bullet. Slide 116, notice the second point talks about the lack of finesse in the movement. Okay, so you have gross movements or not, or finesse movements disappear. So for instance, smiling, certain movements that are very delicate, that are that are complex, but are made up of lots and lots of small movements, disappear because you don't have the ability to create that kind of finesse. Then I'm going to, when we're talking about Parkinson disease, and I'm in slide 119 of the presentation, notice in the first bullet the word unknown. Unknown equals idiopathic equals primary, right? Then we see in the second bullet, when we're talking about proteins being dysfunctional, it is usually because of some kind of 3D or changes to their 3D conformation, okay? Or the lack of a part, a unit, a subunit, what we call, which would be, in that case, genetically based. Slide 121, Notice the first bullet, I have it circled. That and the second bullet, I'll just read it out to emphasize. All symptoms appear with an underline, right? As the disease develops and progresses, severity progresses as well with time. So getting worse with time. Symptoms start on one side, but progress to both sides in the end. Very unique. Um, Then the third point talks about sleep disorders, and I just wanted to indicate to you that sleep disorders have been associated with a list of very interesting phenomenons: obesity, diabetes, how surprising, CVD, PAD, and apnea. And the question is, of course, what can go wrong? Everything. Okay, going on to brain trauma. Slide 123. If we look at the second point, you can see the difference between focal and diffuse injuries, the difference between localized in one area or more than one area. Then you can see the division of brain injuries into close, blunt, and open and penetrating. And by the way, the combination of. Slide 124, we can see that when we talk about blunt trauma, the dura remains intact. I suggest that if you don't remember the structure of the skull and the brain, that you go over it. And of course, we have no exposure to the environment. When we talk about open trauma, open as open to the environment, there is the possibility of, or there is actual connection between the area and the environment. What else? Slide 125. We can see in between the two first bullets the difference between chemical and mechanical impacts. Then the third point, by the way, is kind of a list of the major reasons for cell injury, right? So this proves that the body uses the same tricks or the same mechanisms again and again and again. By the end of the course, you'll be bored with how much it repeats itself, which should make it easier for you to learn. Then in slide 126, in the second bullet, notice that we're going from local symptoms to systematic, which is always worse. Third point talks about, of course, the creation of pressure within a confined area. I'm sure you've heard of it before. And in this case, of course, may be accompanied and most likely will be accompanied by inflammation. So inflammation and pressure. 127, look at the formula there for the severity of injury. It is the outcome of force divided by surface area, which in other words means that we expect a linear relationship between the severity of injury and the pressure, because force divided by surface of area is the formula for pressure, right? Look at the intro presentation again if you do not remember this. Then in slide 128, the thought that came to mind to remind you that in the fourth bullet, the word hemorrhage is always a bad condition, a bad level to be at. Okay, so it's getting worse. Okay, I'm going to stop here for part 2. We will continue from slide 130. Stay tuned.